Hello everyone, my name is Mark Damante. I am a neurosurgery resident at Ohio State University. I'm going to give you a brief overview of our publication on the use of neoadjuvant arterial embolization of spine metastases associated with improved local control in patients receiving surgical decompression and stereotactic body radiotherapy. Our group recently published a study on associated risk factors for progression of spine metastases after stereotactic body radiotherapy, in which preoperative spinal embolization was correlated with improved local control by multivariate analysis. Currently, preoperative spine embolization is used for mitigation of intraoperative blood loss for hypervascular tumors such as renal cell carcinoma. The presented study aimed to directly compare local control and pain management outcomes among patients treated with preoperative embolization, followed by surgical decompression and stereotactic body radiotherapy, versus those treated with surgical decompression and radiation alone. This study was a retrospective review of patients treated with surgical decompression and stereotactic body radiotherapy, with or without preoperative embolization. 47 patients were included in the embolization cohort, compared to 70 patients in the non-embolized cohort. We compared patient demographics and treatment data, as well as survival outcomes, local control, and pain control. This is a Kaplan-Meier curve depicting the significant improvement in local control among patients receiving embolization. Interestingly, degree of embolization had a significant impact on one-year local control rates. Our data suggests that approximately 80% decrease in blood supply to the tumor was necessary in order to see this impact. As you can see in this Kaplan-Meier curve, in which we stratified the degree of embolization as complete embolization being greater than 80% or partial embolization being less than 80%, there was no significant difference between the local control outcomes when receiving partial embolization or no embolization. We also evaluated the potential for palliative pain control following embolization. We noticed that immediately post-embolization, patients had a significant improvement in their overall pain scores only when the degree of embolization was greater than 80%, similar to what we noticed in our local control data. Our study suggests further utility for preoperative spinal embolization outside of the traditional use for mitigation of intraoperative blood loss in hypervascular tumors alone. Potential for preoperative spine embolization to enhance local control and for palliative pain control are unique applications that warrant further prospective analysis and consideration by treating neurosurgeons. I'd like to thank Dr. Brad Elder, Director of Neurosurgical Oncology, and Dr. Blakaj, Director of Head and Neck Radiation Oncology at The Ohio State University, as well as the rest of our spine oncology team for their contributions to this study. Thank you for listening.